The first episode of American Compassion set out to answer a few questions. At the turn of the last century, what did it mean to be poor? Where did people find help when they needed it? What was the idea of a safety net? And in answering these questions, we found out a few things, like there were always concerns about who was deserved of care. There were always concerns about private wealth and the role of industry in providing this care. There were always problems with distributing federal funding for programs locally. We discovered that the safety net wasn't just about healthcare and housing and food, it was about safety and infrastructure and access to art and literature and education, about access to electricity and work and nature, credible media, and so much more. Over and over again, we were reminded that the safety net and the systems that we think today are impenetrable were imagined and built by individuals with empathy, creativity, passion, and vision. Today, we've seen the threads of the safety net unravel. COVID revealed how tenuous the invisible strings of this net are, and as we attempt to mend and reimagine and rebuild our safety net for the 21st century and beyond, we look to individuals with those same qualities, that same drive, and that same mission. And today, we have 4 individuals with that same motivation to rebuild, reimagine, and secure a safety net for a thriving America for centuries to come. Isha Desselle sold everything she owned in 1988 and turned a dilapidated apartment complex in Houston into a refuge for the elderly who needed a home. Today, she has served over 40,000 men and women over the age of 50 who needed food, shelter, health care, and resources. Welcome, Isha.
Thank you. Thank you.
Pritesh Gandhi is a physician who has dedicated his work to connecting the most vulnerable and marginalized Americans to medical services and basic healthcare resources. As the Associate Chief Medical Officer and Director of Adult Medicine at People's Community Clinic, as Chief Medical Officer at the Department of Homeland Security, and currently with Walmart as the Chief Community Health Officer. Welcome, Dr. Pritesh Gandhi.
Thank you.
Minnie Kahlon, did I say that right? Because I always say Kahlon, but it's Kahlon, isn't it? I don't know. Oh, you don't. She began her career in medicine as a neuroscientist, and with intense creativity, intuition, and of course, curiosity, found her way to Austin, where she was the Dell Medical School's founding vice dean of the health ecosystem. Her focus today is identifying opportunities to rapidly improve health through programs embedded in people's lives, getting the data to prove how empathetic connection can address chronic conditions such as diabetes, depression, and loneliness, and building systems to incorporate these innovations into our healthcare, our workforce, and our safety net. Welcome, Minnie. And finally, connection is a huge part of Erine Gray's relationship to the safety net as well. Life experience and working in public policy taught him the importance of access to information and resources when in times of need. And that when it came to this access, there was a huge gap for most Americans. After 9/11, and with a background in computer science, he decided to pursue an MPA from the LBJ School of Public Affairs. Yay! And Erine went on to build Findhelp, the nation's largest social care network, to connect people to programs that improve outcomes for some of the most vulnerable Americans. Welcome, Erine, and welcome, everyone. Thank you so much for joining us. So, Erine, let's start with you, because the idea of telling the story of the safety net was a large part of what motivated you to start doing a podcast. So talk a little bit about how you see the history of the safety net and the importance of the safety net today. What is it, and what is your role in it?
Thanks, Rebecca. So it is beyond surreal to be here, having graduated from the LBJ school 20 years ago. Last night we went to dinner and we talked a little bit about what we may talk about, and probably the most exciting part of the dinner was the free parking permit that Alex gave me to park in the LBJ lot. And I've been smiling since basically 10:45 when I got here. During that time in my life, I was a programmer and was in New York on 9/11, and probably the first time in my life I felt this small, sort of realizing that we are sort of a speck in the universe, and did a lot of soul searching, and decided on a whim to apply to the LBJ school. In fact, I missed the deadline. And I emailed the admissions office and said, well, I missed the deadline. Can I still apply? And for some reason, they said yes. And then I came here. And, when you change careers and you sort of start somewhere where you don't know anything about the subject, a little bit. I used to watch Meet the Press, but that really didn't give me much guidance or much of an advantage. But it was here, understanding that every day in classes, you're learning from former secretaries of Health and Human Services. I took a class with the city manager of Austin at the time. And sort of the magic of, I would just call it public service, is not, I think what I learned, it's not the politicians that get things done. It is the folks that are 2, 3, 4 layers below that thrive on those details. And I think that's where the interest came, for me. Really where the passion came from is that you look at society and you look at solved problems in society and problems beyond solved in society. And then when we looked at the safety net, I had a chance to study a mental health program in the first carve-out program under Medicaid in Texas with the first behavioral health service. And we studied the data for a year, and it was a combination of government funding and a private for-profit company that did that work. And you saw the pros and you saw the cons and you debated the outcomes and you wrote a big report at the end. And I think that was sort of the first realization that the people sort of deciding this structure, this fundamental thing in society that we take advantage of, probably were making it up as they were going along. And so that started a lifelong infatuation with, why does the safety net work the way it does and why were certain decisions made? And I think the big realization for the podcast was that everybody comes with ideas. And sometimes when there's a surface level of knowledge, the ideas sound very obvious, but you quickly understand why those ideas are not going to work. So if we are going to fix the safety net, we first have to understand what it is and why decisions were made in the first place. Because if and only if we understand that, we can avoid mistakes that have been made in the past and actually make material progress.
Yeah. And all of you are working at such different but connected parts of the safety net. I should talk a little bit about your work that you do, what you see, and how you see that maybe working in other cities across the country.
Well, with the shelter for the elderly homeless, at any given time I have close to 80 people. And there is a variety of so much need. I am never looking for people. They're always looking for me. And that has been from day one. I could have somebody come from the hospital that is undergoing cancer treatment, and now they cannot work because they didn't plan on this illness, whatever illness that they have. And they will spend every penny that they have just to live.
Yeah.
But a job that they have will drop them because they cannot pay for the insurance. Then it gets to the point where that situation is the hospital will not keep you just because you're dying. But so they don't want to put them to the streets, so they'll call us. So with the shelter, some will die with me. I never like when they die. Some will, in less than 6 months, will get a job and move out. Some will pair up together. Some receive disability Many, we help them to get their benefits if they're eligible for any benefits, and they will pair up, get an apartment, and move on. When it comes to a system, I did not know about Safety Net and Findhelp. It's desperately needed, I could tell you that. The hospital calls me, the police calls, the city calls, the people call. So having the Safety Net, the group where they would call you guys and different services to be connected with whoever needs would be a tremendous thing.
And you know, one thing that you mentioned, which I think is such a huge, I don't know, does anybody have really a great, healthcare story from the United States? It's very hard here to get healthcare. It's very hard to afford healthcare. It's very hard to get insurance, especially if you're unemployed. It is a difficult system to navigate.
And some will die before they even get approved.
Exactly.
It's really crazy. Yeah. It's,
exactly. And, Pritesh and Minnie, you're both working in this healthcare space.
Yeah.
Talk a little bit about the work that you're doing with healthcare, why healthcare is such a difficult element of the safety net to think about, to reimagine, and to rebuild, and how you're trying creatively to do that.
Sure, I'm happy to take a second and do that. But I will note is, and I'm sitting here jotting down things that come to my head and listening to you, the thing that comes to my mind is that, often systems exact harm, right? Unless you can really change the system completely from inside, often systems exact harm. And what you'll find is that there are people inside really broken systems trying to do the right thing, and then there are people on the outside who are trying to create, new systems from scratch. And the reason that came to my head was that as you were talking about how people come to you and you'll get calls from government and from hospitals and others, I'll tell you, I remember, I guess this must have been in March of 2021, sort of right at the height of the pandemic. I was 2 months fresh on the job as Chief Medical Officer of Homeland Security, and I was down in South Texas in Donna. And I remember we had tens of thousands of children in our shelters at DHS at the time for a variety of system failures, to be honest. Because just to take a second, children have to go from our shelters at DHS, from our really holding centers, over to HHS and then over to more permanent shelters. And this is not the topic for this conversation. We can talk about it later. But what I will remember is that, do you know what we did? I was the top physician at the third largest federal department, and we had FEMA and CBP and ICE and all of these players, and we were calling Sister Norma in South Texas and her church. And for those of you that are native Texans like I am and know Sister Norma and know the system there, and that's what we did over and over and over. It was Sister Norma there. In El Paso, it was Reuben at Annunciation House, and in Laredo. And I can go city, and I'm getting goosebumps and a little bit of PTSD, but that's a whole different issue. But, I can go county by county, city by city on who the people are.
Yeah.
Mr. Rogers says, where are the helpers? Where the helpers are. And it is both, it is simultaneously reassuring that there are helpers out there and completely demoralizing that this is the state of healthcare in this country, and it's not any different when you're working at a community health center. And I see practitioners in the room here. And when I was at People's, the FQHC in East Austin, it's who did you know? We were just talking about this, Dr. Pont. Who do you know and his words, who do you know at the YMCA at 5:00 p.m. because you've got this patient here with you, or hey, you've got this pregnant individual, and needs a doula, and who do you know at Mama Sana here in Austin that can take care of this individual? And so, and when I was again at DHS and trying to figure out, working out with the COVID-19 team and listening in on conversations around vaccine distribution, it was people in a very guerrilla warfare kind of way, identifying who the people are in the states and the cities and the regions to be able to distribute vaccines to, and built on personal relationships. And so in the vacuum of a system, you have a social safety net that's made up of righteous individuals that are trying to do the right thing. Again, reassuring and actually very frightening.
Yeah. And one of the things that came up in the history of the safety net is this kind of dichotomy. It's, will people stop helping each other if there's more help for the government? You know, and that's a question that was asked at the turn of the last century, and it's still maybe ideologically there, which is we don't want people to stop helping each other. I mean, we have to be connected. I mean, Minnie, your work shows that gives the data for this type of empathetic connection, and Isha, you know, Houston would be much worse off without your work. So, but I don't think necessarily that there is that trade-off. You know, it's not one or the other, perhaps. So we can get into that in a little bit. But Minnie, let's talk a little bit about your work and the importance of that connection.
Yeah, I'll start by sharing my reaction to, in some ways, to what Isha was saying as well, which is awe and admiration, and then how Pritesh built off that and said, awe and admiration, and in the end you have this massive investment in these massive systems, and they're relying on individual people and individual efforts. And I'll just share that my reaction is anger. Now, maybe I'm not supposed to be angry at a compassion-focused podcast, but
Sure.
but we have to go through anger to get to compassion.
That's right.
And I think I want to first reserve my compassion for people, and then after that, systems. But really, I think my interest in this topic comes from a couple of places. One is that I'm an immigrant. I'm a self-selected, relatively privileged immigrant, and it has defined who I am. It continues to define who I am. And because of that, I have a very particular idea of what America is and should be about, and I'm, you know, born-again American with my passion and sort of zeal for this ideal of a place that lifts everybody up, that is open to the world, sees the best in everyone, and achieves great things. And so in the pursuit of that, over the years that I've been here, I've been devastated by how distant we are from that ideal. Don't get me wrong, I am proudly American. I stay here, I critique the things I love, and you bring that sort of passion to it. But especially as I dove more and more into healthcare, you just cannot but be frustrated by all the limitations. And you know, Pritesh's description of like, here I am looking for Sister Norma, when I have all of these, you know, the system is supposed to be here to help. Again, let's just get some numbers straight. So healthcare is now $4.8 trillion. 20% of our GDP, when every other developed country gets better results with half the amount spent per person. So by my math, there's like at least $2 trillion, maybe $2.5 trillion just sitting around that could be invested in other things. It's not just about reducing cost. It's about the opportunity cost of spending all this money on this system that sits there while Pritesh tries to contact Sister Norma, right? Or Isha struggles to get a grant. Now, she's very successful at it, so I shouldn't use the word struggle. She's very good at it, but she goes to get grants for her essential work. So the way I look at it, we've got $2+ trillion that need to be reinvested. Now, how fun to think about all the things we can do with $2+ trillion. And that's what I'd like my next, I don't know how many years, focused on. As part of that, what I have landed up on personally after decades of trying to work through science and through academic medicine, these have been my two levers. So about a couple of decades using science and using academic medicine, which is a particular structure that is about bringing people invested in changing the world, who are interested in learning and developing new interventions, putting them all together into a healthcare institution and hoping that that healthcare institution is now better positioned to do things, hopefully not just calling Sister Norma and bringing more to the table. The reality is, I don't see that as being today. I don't see that as being a viable approach to true community and population health and getting around the problems that Isha is addressing outside of academic medicine, that Pritesh is addressing outside of academic medicine, even when he was a physician working at People's Community Clinic. And so in addressing that, what I asked was, how can we get health to people in such a way that we deliver results that are stunning, so stunning that maybe this $4.8 trillion system would actually pay for those outcomes, even though it is not used to doing things that it doesn't want to do. And that has taken me on a path to get to human connection, which we thought was the most sort of the basic unit from which we could build backwards. And so we work on programs where we try to reach people in the cadence of their lives, starting with those that have the least, that face the most barriers, and create a service which makes people feel like VIPs, because they are, and then working backwards from there, start adding and layering on what they need, and eventually, as they need it, maybe they touch the healthcare system. But trying to protect them from the friction, the expense, the hassle, the stress, the being made to feel like you're stupid parts of the healthcare system for as long as possible by working with them outside, and then when they need clinical care, really getting them to some of the best clinical care as possible. So that's the journey that I'm on right now, and I've been able to do some science and get a little bit of traction in that direction.
Yeah.
Do you think there's enough money?
Erin.
Do you think there's enough money? Because you mentioned meaning, is it a money problem or is it a design problem, in your opinion, with all your knowledge?
It's definitely, there's money as a part of it, but the money is in the system. The problem is taking the money out of the system, and the system is a complex system that is designed to keep itself alive. So it is truly this other beast that just sits there, and all it'll do is just keep readjusting to keep itself in motion. There are too many vested interests. You don't even have to ascribe bad intention to any of the players. Any of the players. I mean, big pharma and pharmacy benefit managers and big hospital systems, and you don't have to ascribe any ill intent. And you would still be stuck with a system that just keeps itself going. So there is enough money. The question is how we get that money to pay for the right things. And just as one example, when there was a really fantastic federal program called the Accountable Communities for Health. And it was a program that was designed to consider the safety net, to consider compassion, consider the kinds of services that Isha is doing, and say, you know what, actually, these services that Isha is doing to stabilize people, to give them a home, caring, connection, dignity, these are really important. So let's test healthcare with that. Mm-hmm. But you know the way it was done? It was done by providing money to healthcare institutions, the $4.8 trillion, to be better organized, to reach out better to Aisha's organization. All that money went to the healthcare institution, not to Aisha's organization, not to the social service agencies that were to be connected to. So even to your point about design, even in design, we keep going back to the same old, I really think of it as a spot under the, you've got the spotlight, and the key is somewhere else, but there's the spotlight, so you just, healthcare, here it is, so let's put money in the same place. Whereas, the idea was that healthcare would be more organized to reach out and to send people to a food bank, to Aisha's organization, and they would just somehow take those people and continue to support this expanded group without the money. So I think it's a question of where the money goes and how we get at it.
Yeah.
No, I have something to say.
Yeah.
One of the biggest problems that I had when I first started, when the people go to the clinic, it's a different doctor each time. And people who were never on medicine through MHMRA are put on medicine. So the system was actually worse. So when you have a person who's never been on medicine and they're so drugged up, and they have medicine conflicting. At one time, I had a lady who came in, put all her medicine in a brown bag, half a brown bag, grocery bag. Here it is. What does this lady take? Then you're so drugged up in all this medicine, you don't know which, did you take it? Did you not take it? That's not an issue now. But this is crazy to have people on medicine where the money is going to. and you keep them drugged up. That had to change.
So it's about the system, but it's
It is
also
about
about
the system.
navigating the system. It's also about who is responsible for the system. And to Minnie, something you said, there is money, but we have to make sure it goes to the right places. And who is deciding what are the right places, how to invest and where to invest our money? You know, Pritesh, you work for Walmart. Walmart had a very interesting idea about how to provide health care. Erine, you were also, Findhelp was part of the endeavor to provide this. Talk a little bit about what that idea was and how you're trying to navigate it.
Sure. You're saying it very nicely, and so I'll try to say it equally as nicely and keep my job. I came to Walmart because Walmart, 90% of Americans live within 10 miles of Walmart, right? And I think like half this country enters a Walmart every week. And for someone like me, who was just coming from Homeland Security, which I think more Americans touch Homeland Security than any other department, I wanted to continue working at scale. And so Walmart has this real opportunity in particularly rural areas around this country, but rural, urban, where it's actually a trusted brand. And so what we built was a platform, a digital platform, integrated into Walmart.com, where if you were on Medicaid, and the test sites in Georgia and Ohio, if you were on Medicaid with a certain managed care organization, integrated into Walmart.com, you would have access to, if you're pregnant, a doula, and you'd be able to get a birth plan. You can just think about maternal mortality in certain parts of Georgia. You'd be able to get a birth plan, multiple doula visits all the way through pregnancy into the what's called the fourth trimester. You have access to a dietitian and a meal plan, but a meal plan that's dynamic based on your shopping cart and your consent, of course. But the dietitian, being able to work with the dietitian sort of in real time to be able to adjust your diet. We put community health workers in the Walmart stores, actually, and the CHWs through the Findhelp platform would have access to all the social needs resources, and sort of a host of others. I had $50 a month to spend on healthy food as part of the Food is Medicine national movement. And so all the things that you would need to start to pick at this mountain of a problem around chronic disease in this country, right? Of that $4+ trillion, 90% of it is driven by chronic disease. I mean, we have toxic food systems. I don't have to say, this crowd here knows, and you all here know, the influence of the American lifestyle on our health. And so this was to chip away at some of that. The challenges to the conversation we've been having earlier is that we built all of these things and built a price point at cost, but we couldn't get it funded by organizations who hold the majority of funding for healthcare in this country, right? And so, if you talk to managed care organizations, they will tell you, large health insurance companies, that for Medicaid in particular, the margins are really thin. And so, I'm just going to use sort of made-up numbers here, but if that product that we've built costs us, an actual cost us, let's just pick a number, $100 per member per month, a health insurance company may say, well, we can only pay $5 per member per month for it. And some of the reasoning is that because individuals are almost always with that plan for just a year, there's disincentives to want to do the long-term investment. This is the problem we're in repeatedly in this country, that unless you're Kaiser in California, who owns the entire vertical, so you've got the plan, you've got the providers, you've got the specialists, you own the hospitals, you own the entire vertical, and people stay with you for decades. There you have an incentive to invest. But for everybody else, where is the incentive? If you're an insurance company and your member is going to bounce in 12 months or 14 months, like, very hard to justify the day-to-day investment to address long-term health outcomes. They're not going to reap that benefit for months to come. And we see it across the board, right? Like, look at SNAP eligibility, has to be redone every 6 to 12 months. Look at Medicaid eligibility, has to be redone every year, so et cetera, et cetera. And so these are the headwinds, right? Best-in-class platform, first-in-country, native digital integration into a large, Walmart.com platform, integration with doulas and dietitians and referral platforms for social needs. But the economic model is profoundly challenging to get funded. And that's problematic because, I work at the Fortune 1 company and am really struggling to try to get this done.
Yeah.
Candidly.
And you would think, well, they're a business. They can fund it themselves, right? There's this idea that big business operates a little bit differently than, say, the government. They need different types of funding. Can you talk a little bit about the role of business, or Erine, you also can, the role of business, the role of large companies in the safety net, in our healthcare system, in our housing system? I mean, when we talk about responsibility, it's a very interesting question. And how do you see that?
That's a good question. It's interesting sitting, here in the LBJ school again and thinking about that question. And I'll share a story. I was after I graduated, I spent 6 years in government, and really cool project in Texas where the governor at the time, Governor Perry, and the Secretary of Health and Human Services, Albert Hawkins, who was an LBJ grad, had an audacious goal, and that was to simplify the way people enroll in public benefits, SNAP, TANF, CHIP. And I really wanted to work at that project, and I applied for a job at one point, and I didn't get it. And then through the LBJ listserv, I saw a job opening, and I applied, and I ended up getting it. And there is a drop-off after 6 months. CHIP at the time had a drop-off after 6 months, meaning if you did not submit your renewal application, your kid was uninsured. And so what they were trying to do, basically, is just make it simple. And what the commissioner used to say is he wanted to add dignity to the process. And it was less partisan back then. But we were in the weeds of that project for 4 years, and we were trying to modernize the application process using internet for the first time, call centers, so people didn't have to take the day off of work to go to the local office. And then the financial crisis happened in 2008. And the demand for SNAP went up a large amount. In fact, there wasn't enough people to answer the phone calls, and a terrible story. But if you remember, cell phone minutes weren't unlimited way back in 2008. So you might have a cell phone plan with 100 minutes. And when the state designed the electronic IVR system, they never imagined that somebody would wait on hold for an hour. So somebody would be calling a call center about a desperate benefit, and sometimes they didn't go to the doctor until they got lots of times they didn't go to the doctor until they got their Medicaid benefits approved. And so they would wait patiently on hold. They're in desperate situations, and then they're hung up on because there wasn't enough people to answer the phone. And that stuff happens, and I blame private business, frankly. The vendor that had that contract was $1 billion contract, $1 billion contract. So we worked really, really hard to fix those technology problems. And one problem in particular was the state has bilingual call center agents. And what was happening is they were answering the phone, and they were looking at they were speaking in Spanish, and they were looking at the work instructions in English. And then they had to translate back to Spanish and go back and forth. And so they brought it up, and they basically said, it's really stressful to do that. Can we just have a website with the work instructions translated to Spanish? I'm not making this up. It took the project a year to implement that change. And so that, for me, that was a moment where I'm like, you're not going to disrupt it from the inside. And the only way to try to disrupt the safety net is from the outside. And shortly after, I made the decision to start the business. And there is more freedom, for a business. And some say that the job of business is to maximize shareholder value. And that's not a bad thing. I think the for-profit model has changed the world. I think Walmart has changed the world, certainly for my hometown, in a very positive way. And But maximizing shareholder value, is it the short term? Is it the long term? That's where the decisions are to be made. And I think as CEOs, we have to be thinking a lot more long term. We have to point out wrong when we see it. Even if it means you get criticized, even if it means you lose a contract sometimes. And I think if you do that, you have a chance overall to actually have an impact. The problem is when people get milquetoast about things they're passionate about, and they're unwilling to make those changes. And I think that's when businesses begin to die. So very much a believer that disruption is necessary and possible from a business perspective, but they can't go rogue. It has to be a partnership with government. There has to be regulation. There has to be minimum things so that people's basic needs are taken care of. A bit of a long answer, but this is my 2 cents on that.
Yeah, and Minnie, you're starting a new company right now, Beheld. How does that speak to you as you're starting this endeavor?
Firstly, a lot to learn from Erine on this. As I've told him, I want to know all about the mistakes he's made. I mean, this is commitment. 14 years, building what was the first of its kind. It used to be called Aunt Bertha. Yeah. I remember it. There were very few tools to help people get the resources they needed. And Aunt Bertha was the first that I knew of. And I thought, wow, somebody who is really trying to solve the problem has started this. So really lots to learn. Yes, so I have decided to, based on some results that we've gotten, so we've been really looking at how do we help people who have a lot of barriers, who have the least resources, to get better health by integrating into their life. We've done some clinical trials. I'm a scientist, and I'm still faculty at Del Med, and we run clinical trials that are usually used for drugs, but instead here we've used them for non-drugs, but getting results like drugs. So in our case, this was human connection. Literally, conversations in, biology out. We test hemoglobin A1C for people with uncontrolled diabetes. Our results in managing diabetes have been so striking that I had a couple of options. One was to do what academic medicine does, which is you publish your paper and maybe try to get people to look at it, and then you hope for the best. I've been in the field for a very long time and trying to change the system, and I was not satisfied with publishing my paper and hoping that somebody would do something about it. Number one, wasn't going to happen. Been there, seen that. Doesn't really work that way, especially when what your trial is about is not easily fundable. If my trial was about a drug target, no problem. I could publish it, sit back. Tons of people that know how to make money off of it would jump on it and run with it. But our trials are about human connection, seeing somebody for who they are, dignity, making sure they never wait on the phone, ever, that before we pick up the phone, we know that somebody's preferred language is Spanish or Telugu or whatever. And so A, would not be picked up. B, it would be done badly. So in healthcare, and as we think about the safety net, and this really loaded word, compassion, and this other word you use, milquetoast, I love that. You can't have a milquetoast approach to compassion or to make any difference in the safety net. And so I was pretty sure that if I just published and if someone picked it up, they would have a milquetoast approach to our beautiful, not just mine, because there are a lot of people that have been involved, our beautiful, beautiful work. And so I'd be damned if that was going to be the answer. And so I've started a small venture. I made a decision not to make it a nonprofit for some other discussion. It's a public benefit company where we would actively seek public good as well as shareholder financial value. By the way, the standards are so low on that. It just means that you are allowed to discuss financial, in addition to financial goals, you're allowed to discuss a public goal. That's what it means to be a public benefit corporation. But let's start there. And the reason it's one of the reasons it's a company. It's because the industry we're tackling and the industry that we would like to have pay for effective solutions, whatever they are, is the healthcare industry. And healthcare is big business. I think we keep forgetting that, because on the other end, it's people that get, we want to help, and we keep forgetting healthcare is capital B big business. Top 10 Fortune companies are all like healthcare companies, including these weird intermediary companies that you wouldn't know there are healthcare companies, but actually are healthcare companies. And so that's the road I've just begun. I'm going to learn a lot from everybody here who, entrepreneur, worked in big business, entrepreneur.
Yeah. And I mean, big business, but also sometimes we forget they're vital parts of a lot of community and city economic programs. I mean, this is how these are major hubs of how people are making their livelihoods, and their lives. So I think that's also it's easy to see something as big business and think, oh, that's the problem, but it's difficult to see that no, this is actually these are massive parts of our world, how we make money. Nurses and janitors and doctors and administrators and people are working in these healthcare systems, and they also have to navigate the healthcare systems. And we speak of systems, Isha. We were talking last night, and you were mentioning grants are out there, funding is out there. You have to be effective at grant writing, and you can get the funding, and people can do this all over the country. So this idea of disruption, how does it set with you? Because you are working within the system, and you are providing help, but there are other huge problems also that need to be disrupted, but you're working within it. So how do you feel about this?
It's crazy. What I provide is what's needed, and then work with the various different organizations. However, they have organized themselves, so we only go to them. So whatever safety net you have, and who the communication is not there with the city and local companies to get the service. Frustration from our part is more than 50% of the people that we have pays absolutely zero. The other part of the people who pay something help take care of the gas, electric, water, and whatever maintenance. So while I only apply for funding when I need funding for a particular project, there is so much more help the individual need that we don't even begin to touch.
Yeah. I think that's a really great point, because part of what we're talking about is this is a whole person. What it means to have a robust safety net means that people have access to the internet. They have access to art and literature and education, libraries, not just healthcare. But because healthcare has become this system where we're constantly having to prove our need, we forget sometimes that these are other parts of the safety net that are important for us to thrive as individuals and as citizens. Pritesh, how do you think about that when you're thinking about not just healthcare, but you're serving, these whole people and incorporating different elements of the safety net into the work that you're doing? Where does that sit with you?
It's an important point, and I think folks in the audience here know, but I'll say it just for good measure, which is 80 to 90% of an individual's health outcomes are driven by their social determinants of health, right? And I think, we've seen that statistic parroted repeatedly. I think, again, though, it gets back down to the same critical issue, which is we have a profoundly short-term view of people and their health and livelihoods. It's the same reason why we don't fund early childhood education in this country, right? Like, for folks that are, I don't know, here in the audience if we have any childhood education sort of experts here, but for those that have paid attention to studies dating back from the 1970s and 80s in North Carolina and elsewhere, I mean, these studies show that when you invest in high quality early childhood education from age, 3, 4, and 5, even if that child then gets mainstreamed into just their regular, public school that they live, in where they live, the outcomes are markedly different when they're 18, 19. Higher high school graduation rates, lower teen pregnancy rates, lower incidence of chronic disease. I mean, this is evidence that's been around for decades. I forgot the name of the guy from Chicago that won a Nobel Prize for it. It'll come to me, maybe not, maybe someone in the audience knows, but very well studied, right? Yet here we are decades later, unable to get over the policy inertia to be able to actually make that investment. I think this is the same predicament that we've been in for a while, as I mentioned earlier, SNAP re-enrollment, Medicaid enrollment, and then the churn that happens. I mean, here's the reality. Healthcare dollars live inside the largest payers in this country, the federal government. People are churning from plan to plan to plan, year to year to year. Who is going to make the investment? Where is that going to come from, right? I mean, I think that's an open question that there is not a good answer for right now. Now, there's enough innovation coming down by CMS year over year, and even this year, for example, you'll notice in the recent rule from earlier this year from CMS, we're putting funding mechanisms in place to reimburse community health workers for the work that they do, but it is far too small and far too slow and very complicated. I looked at that rule. I have a hard time understanding that. And to think about, I led for a couple of years Walmart's community health worker program. We had community health workers across multiple states, across 50 plus sites. Incredible investment in community health workers, but completely blew my mind thinking about how we were going to do reimbursement and the regulatory oversight and the entire model to build that system. So it's very complicated, and I don't have a good answer right now. I think that's the struggle. We've spent quite a bit of time today talking around, what are good stewards? What do good stewards look like in healthcare in this country? How do we rethink? Let's just be very clear. We need to completely frame shift healthcare in this country. It's completely broken, horrible outcomes given the profound level of investment. All of that being true, how do we entirely frame shift in terms of where dollars are flowing? Because here's where dollars aren't flowing, as we've talked about, to the last mile service providers. They don't get, with all due respect, all of, Findhelp has revenue that comes from the model, organizations I've worked at, large insurance companies, providers, nurses, you go bit by bit by bit on every single part of the healthcare delivery model, all the way down to last mile care.
Yeah.
And where is that money coming from? Yeah. That's the challenge. And you guys are involved in some really interesting models where, you guys are pulling together large social service organizations into networks to be able to funnel money. There's great demonstrations in New York and elsewhere. I know you guys have been involved. Maybe speak to that a little bit. I think that's the path forward.
Yeah, I can talk about what's happening. But for those that are unaware, what Pritesh was talking about was of all the Medicaid dollars spent, let's say it's $1 billion, just for a round number, there is a new rule that gives states some leniency to allow health plans to spend some percentage of that for social services. So what used to be, you go to a doctor, you go to the emergency room, all that's covered by Medicaid, but social care wasn't, food wasn't, and having gone here and understanding the Great Society, there were arguments about what should be covered under Medicaid when Medicaid was passed, and we didn't get to that yet. And what's slowly beginning to happen right now is the last couple of administrations have been trying demonstration projects that allow this experimentation, and there are pigs at the trough. I hate to say it. There's many layers that are there, but I'm actually a little bit more optimistic these days, and it's not because of the federal policy. That's not the primary reason. And in my discussions with our customers, we have 130 or so health plans as customers of ours, and I've yet to meet the evil person, honestly. I really haven't. It is, maybe it's just the divisions. I'm not talking to the actuaries, things like that, but maybe it's just the divisions that are, doing this social work and doing these things. And I just think there's not enough Ishas in the world. There's not enough Sister Normas in the world. There's not enough, minis in the world, and if we're going to, I think the thinking is if we're going to make some changes, it has to be a lifetime commitment. And so, this is a podcast about the safety net, but one of my heroes was Frances Perkins. And for those that aren't aware of who she is, she was the first female secretary in the FDR administration. She was 12 years as Secretary of Labor. And so she witnessed a factory fire, the Triangle Shirtwaist Factory fire. And she dedicated her life to preventing tragedies like that. But what does dedicating your life mean? It means going to the Capitol in Albany to fight for good legislation. She made such a name for herself over the years that she befriended FDR. Actually, she didn't love him at first, but he recruited her to be a Secretary of Labor, and she refused the very first time. And then he basically said, I disagree. Literally, she said, I'm not taking the job. And he said, I disagree, in a letter that went back and forth. So she basically said, I have some stipulations. And she basically said, you need to adopt the concept of social insurance. And that is Social Security. That is the Conservation Corps. That's minimum wage. That's overtime. That's unemployment insurance. And the way she did it was, the president isn't all-encompassing power. She used to walk to the Capitol every single day to build relationships, one member of Congress at a time. And she would actually write congratulation letters to newly elected senators and members of Congress in order to build that relationship.
We found one here
in the archives?
In the archive that she had written to Lyndon Johnson.
And the reason why she was able to get all of those things passed is, and this was a quote from a book that I read, she would compromise ruthlessly if it meant making progress. So what's happening is I think we're living in an era of no compromise. And I think sometimes we aren't willing to accept that it is going to take a lifetime commitment to these problems. And then, I don't know, in 1988, you imagine you would have helped 80,000 people. Would you have thought that?
My goal was 14 people.
14 people.
That's how many in my family. And I wasn't even a nonprofit. I had no idea what that was.
And here we are, 24 minus 12, plus 12, 36 years later,
36 years.
And that is a life's
With
work.
one big question, if you had 6 months to live, what would you do?
This is going to sound ridiculous, but I would do exactly what I'm doing right now.
Good.
Yeah.
Then you're in the right spot.
Yeah. We have very few minutes left, but just 1 minute. Each of you a positive word about creating the safety net. How are you thinking about reimagining? What is giving you energy as you think about reimagining and working within the American safety net? Isha?
I would love to see a system that people could be able to get to and find out exactly what it is what help there is out there and a solution for them. I would love to see that happen because right now the city's lost how to help. The service hospital, they're lost on so it's a phone call after phone call after phone call, and it leaves people on the streets. There's so many people who've never ever been homeless before are homeless.
Pritesh?
So quick thought. So Erine, the one comment I would make to your earlier comment is that I actually do think there are enough good people out there. I think there are plenty of Ishas and Minis and others all across the country. I think those of us that are seated at the tables we sit at, it's incumbent on us to completely shift the systems that we work in. And I think that's a responsibility that we all carry. The point that I would make is I'm actually very optimistic. I think for those that follow, I'm very interested in food systems. If you're watching the food as medicine movement around the country, it is incredible, right? You're seeing Medicaid start to pay for food to treat diabetes and food to treat hypertension. You're seeing health systems and demonstration 1115 waivers that are supporting housing, again, as a treatment for chronic disease. I think this movement, this notion that, our chronic disease burden is completely driven by our lifestyle. And in fact, there are interventions to be made to mitigate that. And you're seeing dollars start to shift. I think that's heartening. And I think we should ride that and amplify that as much as possible.
Minnie?
Yeah. Firstly, I want to note, I'm actually truly admiring of the people on this panel. Isha, you've heard about what she did and the decision she made to transform her life and do the work. Pritesh's fancy titles that came later, but I've known Pritesh since he was a physician at People's Community Clinic, doing the work. You started, Erine, 14 years ago, and you stuck with it. That is doing the work, understanding what was needed and making it happen. And that, I think, is the way, it's a very actually American way forward, like doing the work, taking on risk, personal, family, and moving ahead. And in that spirit, I think that we have an abundance of human talent. I'm excited about connecting that human talent to others that may temporarily be in need of it, but in the future, once they are better, they can then be the talent to help. And I think we can create a movement. I think there is systemic, to Pritesh's point, I think there is systemic, and to yours, Erine, there are systemic trends that are in the right direction. So I'm very optimistic. You have to be when you set out and take a risk, but I'm excited about the future.
I do remember that meeting, actually, and now that I think about it, I was nervous because that meeting was a big deal. Going into the Dell Medical School and talking to the person designing, the experience. Part of the goal of this was to inspire people to dedicate their lives to try and fix the safety net. I think part of forming the Stories team, when I recruited Jim, I sold him on that idea, and fortunately it worked. And I was sitting out eating my cheeseburger in the lounge upstairs because I skipped breakfast, and I it's been a while since I looked at the mission, but it says our mission is at once the oldest and the most basic of this country, to right wrong, to do justice, and to serve man. And there's nothing more rewarding than finding your calling and finding your mission. And you don't always find it right away, but working in this field you're not going to get a lot of recognition. Probably not, and you're probably going to get more heartache and pain. All of us have experienced it. I would never know what it's like to hear the situations that everybody hears, and I don't think I could do it. But that feeling you get, when you're done for the week is you're just riding on air, and so just encouragement that. We get one life, and the opportunity to go do this work for a living, and in the early days, you figure out how to survive. It does come later. I would just encourage others to jump all in and take that chance.
And you can find this podcast and other conversations about where you can get involved, how you can get involved, who is doing work, and to maintain your inspiration and motivation about getting involved with the American Safety Net at AmericanCompassion.com. You can also find the story of Frances Perkins in Season 1 of American Compassion, the story of Lyndon Johnson and the Great Society in Season 2, and so much more wonderful history. We encourage you to email us at hello@AmericanCompassion.com. And a huge thank you to Isha and Pritesh, Minnie, and Erine for being a part of this conversation. A huge thank you to all of you for coming out. Thank you so much. Please stay after for lunch and have a wonderful afternoon.